Thank you, Dr. Kim. And now may I have the pleasure to invite my colleague from India, Dr. Sheetal Brar. She is lot into research and training juniors in refractive surgery and PHAKIC IOLs. And today she'll be talking about light scatter and quality of vision post-smile versus EYECRYL PHAKIC IOL. Over to you, Dr. Sheetal.
Thank you, Dr. Sanjay, for the kind introduction, and good afternoon, everyone. I would like to thank Biotech Healthcare and Mr. Devinder Khalsa for this kind invitation. I'm very glad to be here presenting on my study. This study basically wanted to evaluate the light scatter and quality of vision post-smile versus the EYECRYL PHAKIC IOLs. So we all know that we have a variety of options for surgically correcting myopia and myopic astigmatism today. We have surface ablation, LASIK, SMILE, also PHAKIC IOLs. SMILE and PHAKIC IOLs are two leading refractive surgical procedures for myopia and myopic astigmatism. Most of the times, SMILE is preferred for low to moderately high myopia correction, and you can see that this is the range of SMILE, which is low to moderate, 0 to -10. I should correct this, 0 to -12 is the currently possible correction range for SMILE. And PHAKIC IOL covers a much wider range. So from +10 to up to -30 is the range for the EYECRYL PHAKIC IOL correction. So with advances in refractive technology, what has become more important today is not just how much your patient is seeing, but how well the patient is seeing also. So visual quality has become a top topic for research, and this equipment, which is the optical quality analysis system, OQAS, from Visiometrics, is a widely used equipment to assess the postoperative visual quality. This essentially is a principle of this is a double pass technique, wherein there is an isolated light source that is produced by a laser beam, and the image is formed on the retina of the eye. Upon reflection of the retina, from the retina, the light crosses the ocular media twice. So when the light is crossing the ocular media, it basically creates scatter, and the machine basically picks up this scatter, and it gives you a value of something known as OSI, which is objective scatter index. Lower the OSI, better the quality of vision. Higher the OSI, worse the quality of vision. And this equipment also accounts for higher order aberrations and light diffusion. So this was the equipment we used in the study to evaluate the postoperative visual quality between the and compare it between the two procedures. So the primary objective of the study was to study and compare objectively the postoperative quality of vision using the OQAS in eyes undergoing EYECRYL PHAKIC IOL implantation versus SMILE Pro for myopia or myopic astigmatism. Now SMILE Pro is basically the same SMILE procedure, but it is done using the Visumax 800 femtolaser system, which is the faster version, 2 megahertz frequency of the laser. So why we wanted to do this study? Essentially, basically because with both the procedures, there could be some factors that may lead to patient dissatisfaction or some kind of side effects to the patient, such as in SMILE, you see there is a corneal interface. Okay, so once you do the SMILE procedure, this interface looks something like this. Under a dilated pupil, it looks like a rough interface, and this interface basically is the source of scatter, and it can lead to, it takes time to recover and heal, and until it heals, it can cause some amount of dysphotopsias. Also, in PHAKIC IOLs, generally, what could be the source of dysphotopsias is the presence of a central hole. And also, since you are implanting a new interface, is an additional interface in the eye, the refractive index of which is a little different from the cornea, so that also could be a source of dysphotopsia. So this is why we wanted to do this study and compare the optical quality between the two procedures. We also had a secondary objective to evaluate the effect of decentration of the central hole with respect to the pupil center in the EYECRYL PHAKIC group, and treatment decentration in the SMILE Pro group and its effect on the OSI. It's an ongoing study. We have recruited 50 eyes from 50 non-consecutive patients so far, with 25 eyes each in both the groups. Now, the eligibility criteria, basically patients with simple myopia or myopic astigmatism up to 5 diopters cylinder were included. The spherical equivalent was within -6 to -12 diopters. Corrected distance visual acuity of 20/20 or better in SMILE group, and 20/32 or better in the EYECRYL group was included, and none of the patients should have any of the irregular astigmatism or scars or pathologies on the corneas. So this is a procedure basically for SMILE Pro. This is a faster 2 megahertz laser. So the energy cut index was 26, a standard cap thickness of 120 microns, and a mean optical zone of 6 millimeter was used for these cases. And this is the preoperative comparison of various demographic and ocular factors. There was no significant difference with relation to the age, sphere, spherical equivalent, cylinder, vision, scotopic pupil size, objective scatter index, MTF, as well as NIBUT. NIBUT is non-invasive tear breakup time. So this is the 2 weeks and 3 months results that we found in the study. In terms of the vision and refraction, we did not find any significant results, any significant differences between the results of both the groups. So sphere, cylinder, spherical equivalent, uncorrected distance visual acuity, corrected distance visual acuity, all these parameters were comparable at 2 and 3 months. However, when we compared the objective scatter index, MTF, and NIBUT, these parameters were significantly better in the EYECRYL group at post-op day 1. At 2 weeks, the objective scatter index was significantly better, which means it was lower, and also the NIBUT. And at 3 months, the objective scatter index continues to be significantly better compared to SMILE Pro, whereas other parameters were comparable. So this is the trend of OSI, or the objective scatter index, for both the groups, and you can see that there's quite a dramatic change in the OSI in the SMILE group. So red is the SMILE. So from a pre-op value of 0.6, it has suddenly increased to 2.3 on the very first day post-op. And at 2 weeks, it slightly has come down to 1.5, but it remains to be slightly high at 3 months. So compared to the EYECRYL group, you can see at every time point, the value of the OSI is significantly higher. So higher the OSI, worse the optical quality. In terms of the modulation transfer function, which is essentially the contrast of the cornea, you can see that there's not much of a change here, but the MTF of the SMILE group is worse compared to the EYECRYL group at all the time points. With respect to the NIBUT values, you can see that at 2 weeks, the NIBUT values of SMILE Pro group are worse compared to the EYECRYL, and this continues to be the same at 3 months. So essentially, this is because SMILE can still produce some amount of dry eye, whereas with EYECRYL, you will have minimum or no dry eye. With respect to the abrasions, we found that there was practically no change in the EYECRYL group. So you can see the higher order abrasions, coma, and spherical abrasions are fairly stable compared to pre-op. So at 2 weeks and 3 months, you can see the abrasions are, it's a flat line. So this shows that abrasions have not changed much. But in the SMILE Pro group, again, there's quite a dramatic change when you see the higher order abrasions. They have increased from 0.2 to 0.38 at 2 weeks, and it slightly comes down at 3 months. Also, there's a slight increase in the coma and the spherical abrasions as well. So we also wanted to study the effect of decentration of the hole and whether this has any impact on the postoperative OSI or visual quality. And we wanted to see where the hole lies with respect to the center of the pupil and the angle kappa. So we used an online software to measure this distance. And you can see in this particular case, the hole looks slightly decentered nasally, and the decentration measured was 0.5 mm. But if you look at the OSI, there is no change in the OSI post-op. The pre-op OSI was also 0.6 and post-op also it was 0.6, so there's no change. So 0.5 mm of decentration did not affect the OSI. This is another case where the decentration looks much more. So the decentration of the hole with respect to the pupil was 0.7 mm. So compared to the previous case, it was bigger amount of decentration. However, if you see the OSI, there is no change. In fact, the post-operative OSI is less compared to the pre-op. So it doesn't seem to have any correlation between the two. This is another case where there was 1 mm decentration of the hole from the pupil, but hardly any change in the OSI. So pre-op value was 1.1, post-operative it was 1.3. So what we found was that with respect to the decentration, it was a mean value of around 0.5, both at 2 weeks and 3 months, whereas in SMILE Pro, we get the decentration data from the PDF of the treatment chart that is available in the laser, and the average decentration in the SMILE Pro group was 0.15. So you can see clearly there was more decentration in the EYECRYL PHAKIC group. This was significant also statistically. However, when we compared this decentration with the postoperative OSI value, because we want to see whether this decentration makes any difference in has any correlation with OSI, and does it affect the post-op visual quality or not. So we found that there was no correlation, and the p-value was not significant, which shows that even if the lens decenters by up to 1 millimeters, or in our series it was a maximum of 1 millimeters, but we did not see any correlation and it did not seem to affect the post-op OSI. Whereas in SMILE Pro group, if you see, there is a very high positive correlation. So value of R of 0.9